and Happy New Year! I hope you all had a very safe and warm holiday season and are making the most of the new year. I'm happy to be back with you to talk about a veritable potpourri of emergency medicine topics this month. Rather than spend the whole time with you going deep on one topic, we'll cover 4 different high-yield topics that can help you improve your practice before you go in for your next shift today. So let's get to it. What we're going to do today is a brief literature review looking at some great papers published in 2016, and while we're at it, we'll supplement with a little bit of the relevant literature from the last couple of years to round things out. We're going to touch on some cardiology to start out, since there is some important new information regarding the use of antiarrhythmics for cardiac arrest, and move on to talk about lumbar puncture and how we can improve our post-LP care. And then we'll wrap up with a discussion on intracranial hemorrhage, whether to give platelets for patients taking antiplatelet drugs, and a talk about the conundrum of the anticoagulated head injury. From my prior talks, I'm sure you've all figured out that I am a huge fan of Calvin and Hobbes, but what's really amazing is how many people have made some absolutely incredible snow tributes to the antics of that kid and his stuffed tiger, and brought some of their snow art to real life. From my prior talks, I'm sure you've all figured out that I am a huge fan of Calvin and Hobbes, but what's really amazing is how many people have made some absolutely incredible snow tributes to the antics of that kid and his stuffed tiger, and brought some of their snow art to real life. Let's start off with the sexy topic. Sudden, out-of-hospital cardiac arrest is something that we see with frequency in the emergency department, as there are over 300,000 deaths from this annually in the United States alone. Antiarrhythmic drugs have been part of the treatment algorithm for this for decades, and there is some data that shows use of these medications does make return of spontaneous circulation more likely. But until very recently, nobody asked the more important question: do more people actually make it out of the hospital with good neurologic recovery? ACLS was developed in 1974 to provide a set of protocols that providers could use to approach a cardiac arrest or other critical patient with the goal of providing a standard level of care. While these have developed over the years and are updated every 5 years, with the most recent update being in 2015, they still involve a number of fairly complex algorithms, medications, and interventions. Over the last decade, these guidelines have come under increasing scrutiny, with questions being raised about whether any of the interventions actually result in improved outcomes. And as a result, some of the fluff is gradually getting whittled away. In this paper, published in the New England Journal this May, the authors addressed the question of whether the administration of antiarrhythmic drugs during cardiac arrest provided the patient with any survival benefit. Hold on to your hats, folks, because this one is a game changer. This paper is a randomized, controlled, double-blind trial that compared the use of amiodarone versus lidocaine versus saline placebo for adult patients with cardiac arrest. They enrolled 3,026 patients over the age of 18 that had a non-traumatic, out-of-hospital cardiac arrest with refractory VFib or pulseless VTAC, which they then defined as having persistent arrhythmia after 1 or more attempts at defibrillation, or recurrent arrhythmia after successful termination via defibrillation. Since they were looking at administration of an antiarrhythmic, all patients had to have IV or IO access in order to be included. Other than the intervention drug, all patients received standard care. They analyzed the data via both a per-protocol and an intent-to-treat analysis, as the intention-to-treat population included a whole lot of patients that were ultimately excluded from the analysis because of various protocol violations, being part of a protected population, having exclusion criteria not known to the EMS providers, and so on. Their primary outcome was survival to hospital discharge, but their secondary outcome was the one that probably matters the most, which is survival with good neurologic recovery. First of all, Let me give major props to the folks that did this study. It was a truly Herculean effort to accomplish what they did in this paper. They started out with over 37,000 patients screened for inclusion that had an out-of-hospital cardiac arrest. They ended up with 3,026 patients. 974 were randomly assigned to amiodarone, 993 to receive lidocaine, and 1,059 to the placebo group. I won't belabor the issue, but suffice it to say that the populations looked pretty similar across all the different groups. The mean time to administration of the first dose of the trial drug was just over 19 minutes after the initial call to EMS, and the median number of shocks the patient got prior to being enrolled was 3. So here's the data. For the primary outcome, survival to hospital discharge, in the per-protocol analysis, there were no significant differences between the groups, with 24% of the amiodarone group, 23% of the lidocaine group, and 21% of the placebo group surviving to discharge. If you looked at the intention to treat analysis, the numbers weren't quite as high and had a little tighter of a distribution, with survival in the amiodarone group being 19%, lidocaine 18%, and placebo 17%. It's important that we look at this because the intention to treat population is probably going to be a little bit of a closer representation to what would actually happen in real life when you're treating all comers rather than a population that's been carefully screened with a fine-tooth comb. As for the secondary outcome, survival with good neurologic outcome, in the per-protocol group, there were no differences between any of the groups, with 18% of the patients in the amiodarone group having a modified Rankin score of 3 or less, 17% in the lidocaine group, and 16% in the placebo group. And there were no differences in the intention to treat analysis either. Now, let's dig in a little deeper. When you look at the subgroups they analyzed, there was a small but statistically significant improvement in survival to discharge for the treatment arms in the group of patients that had a witnessed arrest. If you just take that at face value, you might conclude that earlier administration of the drug might be what makes the difference. But when we look at what happened, there was a larger proportion of patients in the treatment arms that had witnessed arrests, about 28% in both the lidocaine and amiodarone groups, versus only about 23% in the placebo group. As you might imagine, that meant that more of the patients in the treatment arms got early CPR as well. Plus, there was a significantly higher number of patients whose arrests were witnessed by EMS in the treatment arms, meaning that they had earlier high-quality CPR and probably also had faster access to other important treatments like defibrillation. And yet, despite having these advantages, the treatment arms still didn't have better survival with good neurologic outcome than placebo. And as you might imagine, there was also a slightly higher rate of adverse events in the treatment arms than in the placebo patients, although this did not achieve statistical significance. So what does all of this mean? Overall, there was not a benefit to any long-term outcomes with the use of antiarrhythmic drugs in the setting of VFib or VTAC arrest. Just as prior studies have shown, more people did survive to hospital admission in the lidocaine and amiodarone groups, but that does not translate into better survival to discharge or better neurologic recovery. All it really seemed to do was change the destination of death, the ICU rather than the field or the emergency department. This paper is a game changer for me, since there doesn't seem to be a benefit in any of the outcomes that our patients care about, going home or having a functional recovery. I'm a lot less likely to reach for an antiarrhythmic drug during resuscitation, and I'll be interested to see what happens in 3 years when it's time to revise the guidelines again. The amount of effort that went into creating this giant herd of tiny snowmen is absolutely mind-boggling. We do a lot of lumbar punctures in the emergency department. During cold and flu season, I probably do this once or twice a shift. But how many of you were taught that after you do an LP, that the patient needs to lie down absolutely flat for at least an hour in order to prevent a post-LP headache? I was. So were all the nurses I work with. But does this really help? This Cochrane review, published in March, is exactly what we've been looking for to bust this myth once and for all. The authors found 8 trials looking at bed rest versus early or immediate mobilization on the incidence of post-LP headache. And they included data from 1,254 patients, and fortunately, the heterogeneity of the trials was low enough that they were able to combine the data in a meta-analysis. As it turns out, bed rest was not superior to early mobilization. In fact, the patients that got up early were actually less likely to get a post-LP headache. Now, the confidence interval crossed 1, so bed rest might not actually be worse, but it still wasn't beneficial. In fact, the odds ratio for bed rest was 1.21, which means that for every 1,000 patients that has an LP, there will be an additional 40 post-LP headaches among those that are allocated to bed rest. This same trend was true regardless of the severity of the headache, and also for dural anesthesia as well as patients having lumbar puncture. So as far as I'm concerned, this one is sufficiently busted. Since bed rest doesn't help prevent a post-LP headache, we should talk a little bit about some of the other things that matter that we can do. Probably the most important thing that we can do is pick the right needle, using a non-cutting needle like a Whitacre needle, as opposed to a cutting needle like the Quinky. Incidentally, the Quinky is still the one that's included in all of the kits, despite the mountain of evidence that says we probably shouldn't be using it on a routine basis, and the fact that non-cutting needles have only been around for, 5 decades. That's just annoying, and it doesn't make much sense. Hopefully one of the manufacturers will listen to this and realize the error of their ways, but that's wishful thinking. We use an EMR at our site, and one of the few nice things about it is that you have the ability to create a standard order set. So I have an order pre-built into my LP order set that includes a statement like Whitacre needle, size whatever gloves, and LP tray to bedside. And that way, the Whitacre needle is included in the setup. Better yet, when the kits get stocked, have the techs just tape a Whitacre needle to the outside of each tray. That way, it was all the way over there in the supply cabinet 20 feet away isn't a valid excuse not to use it. This is an older paper that came out almost 10 years ago and shows what our anesthesia colleagues have known for decades. If you use a non-cutting needle, you end up needing to do way less blood patches. They looked retrospectively at 505 consecutive patients that had an LP done under fluoro. The big weakness for me is that they didn't include patients having the procedure done emergently, so this isn't exactly our population, but the results are still compelling. Only 4.2% of the patients who had the procedure done with a 22-gauge Whitacre needle needed a blood patch, as compared to 15.1% of the patients whose LP was done with a standard 22-gauge Quinky point needle. If they used a 20-gauge Quinky, the rate was 29.6%, so almost 1 in 3 needed a blood patch. And these guys had fluoro, so they could see where they were going. And so the chances are that their rates of post-LP headache would have been lower than ours would have been in the ED. Yikes! Here's another paper from 2006. It's a prospective, randomized trial comparing the incidence of post-LP headache in patients undergoing lumbar puncture with cutting versus non-cutting 22-gauge needles. It was a small study and included only 58 patients who underwent a total of 85 LPs. But despite the small size, the incidence of post-LP headache was 36% in the group where a cutting needle was used versus only 3% in the non-cutting needle group, with a very significant p-value. Even in such a small group, that was both statistically and clinically significant. This paper is a review article that was published in The Neurologist in 2009, and basically, these authors called out the entire neurology community about the fact that they hadn't adopted the use of non-cutting needles as a matter of routine. Like I mentioned before, our anesthesia colleagues have known about this and have been doing this for decades, and I'm a little bit embarrassed that the ED community is so far behind on this as well. This paper cites a meta-analysis, including 38 trials with over 8,000 patients, in which they showed that the odds ratio for post-LP headache was 0.43 for patients who underwent LP with a non-cutting needle as opposed to a cutting needle. When they separated out the patients having a diagnostic LP, as opposed to those undergoing some form of spinal anesthesia, the odds ratio dropped to 0.35%, with a number needed to treat of 6. Put differently, using a non-cutting needle, for every 6 patients you do an LP on, you will save 1 patient from having a post-LP headache. This means fewer return visits to the ED, fewer missed days of work, fewer blood patches and potential complications thereof. You get the idea. For me, this is a game changer, and I don't think we have any excuses not to be doing this in the ED. I listen to a lot of emergency medicine podcasts and follow a bunch of different online forums. And for some reason, there's a lot of people out there that really seem to hate on the Whitacre needle. But if you'll allow a little departure from evidence-based medicine and permit me to wander off into anecdotal experience for a moment, I'll tell you that I love these things, and I've been using them almost exclusively for the past 6 or 7 years. Anybody who is experienced at lumbar punctures can learn to do this easily, but I will concede that this probably makes the procedure a bit more challenging for the novice. That being said, I find that I'm actually more able to feel that pop right when you go through into the CSF space than you would be if you were using a needle that had a cutting tip. They're a little bit more difficult to pop through the skin, but that's easy to fix because every LP kit comes with at least one needle with a cutting tip, the one that you use when you're infiltrating lidocaine, for example. I usually just use one of the holes that the anesthetic needle made, but you can easily use this needle to create a new hole right at the puncture site if you need to. Even without this, most of the time I'm able to get through the skin with the Whitacre needle without any difficulty. And yes, it is slightly more difficult to advance, but it will advance fairly easily if you just grasp the shaft of the needle near the skin surface and gently advance it from here rather from the end of the needle. This is particularly helpful if you're going to do an LP with a smaller bore needle like a 25 gauge. And in my anecdotal experience, since I switched to primarily using the 25 gauge Whitacre needle, I haven't had any patients return with a post-LP headache that I know of. Although it is certainly possible someone could have gone to a different institution and I don't know about them. But overall, I've had a very positive experience using these. It seems like just about everybody in the universe over the age of 50 is on some kind of antiplatelet medication. The most common, of course, being plain old aspirin. But with cardiac interventions and primary stroke prevention becoming ever more common, more patients are ending up on drugs like clopidogrel, ticagrelor, prasugrel, and the ever-increasingly difficult-to-pronounce ones like eptifibatide. As the population continues to age, we're also seeing more and more people come in with head injuries, most frequently as the result of falls, but also from things like car accidents and so on. And these patients are ever increasingly more likely to be taking one of these antiplatelet agents. Traditional teaching suggests that, particularly for the irreversible antiplatelet drugs, that we should consider transfusing platelets in patients with intracranial hemorrhage that are taking one of these agents. That's what I was taught in residency, and I've been asked to give platelets for various flavors of hemorrhage in the past when encountering a bleeding patient taking these medications. But what does the evidence say? Hold on to your hats, folks, because this is another big one. Up until this trial, we basically didn't have any kind of real evidence for or against giving head-injured patients platelets. This is the PATCH trial, and it came out in The Lancet in May of 2016. This was a randomized, multi-center, open-label trial that enrolled patients over 18 years old with non-traumatic intracerebral hemorrhage confirmed on diagnostic imaging. Patients had to have a GCS of at least 8, so the more obtunded patients were not included in the trial. The patients enrolled had been on antiplatelet therapy for at least 7 days, and platelet therapy had to be initiated within 6 hours of symptom onset. They enrolled 190 subjects, with 97 randomized to receive standard care plus transfusion of platelets, and 93 to standard care alone. The most important exclusion to note is that this paper studied only patients with non-traumatic hemorrhage, so anybody with a head bonk as the etiology of their hemorrhage was excluded. Also, they only included patients with supratentorial bleeds, so again, this may not apply to the cerebellar or the brainstem hemorrhages. Likewise, they excluded subdural and epidural hematomas, and so this really looked only at the patients with true intracerebral hemorrhage. What they found was genuinely surprising. For every outcome they examined, the folks that got platelets did worse. Survival at 3 months was 77% in the standard care group and only 68% in the platelet group. If you recall the modified Rankin score to assess functional outcomes, it's scored like golf. The higher the number, the worse the outcome. A score of 0 to 2 is a pretty good outcome, as these folks are still generally able to live independently. A score of 5 is someone that needs total care for everything, and 6, you're dead. At 3 months, the group that got platelets was more likely to have a modified Rankin score of 4 to 6, with 72% of the patients in the platelet group versus only 56% in the standard care group. The platelet group also had a higher incidence of adverse events while hospitalized, 42% versus only 29% in the control group. And to seal the deal, the platelet group had a higher inpatient mortality, 24% versus 17%. Frankly, this is exactly the opposite of what I would have expected. Goes to show why we have to critically study what we're doing, rather than just basing our treatment on physiologic arguments. Granted, the numbers in this study were fairly small, but this is an alarming trend, and I think that this should make you think carefully before you transfuse platelets into a patient with non-traumatic intracranial hemorrhage who is taking antiplatelet medication. This one was pretty quick, so let's go ahead and just wrap this one up. To date, this is the best evidence we have to guide us on what to do for the patient on antiplatelet therapy with a non-traumatic intracranial hemorrhage. I'm going to say that one more time. Non-traumatic intracranial hemorrhage. Patients with trauma were excluded from this trial, so please don't go arm wrestling with your local trauma surgeons about this, especially since patients with a traumatic mechanism may well have other injuries that require platelet transfusion. The take-home message is that for patients on antiplatelet therapy with non-traumatic intracranial hemorrhage, hold the platelets, as patients who got transfused did worse. Is right. With the population aging, we're continuing to see more and more people being anticoagulated. Unfortunately, that also seems to be translating into an increasing number of people who are sustaining minor head injuries while on these medications. I don't know about you, but we seem to be rapidly becoming a level 1 center of excellence for the elderly anticoagulated head bonk. The problem is that the literature is all over the map about these folks, and we don't honestly know exactly what to do for them. While I think we all agree that an initial head CT is certainly warranted, there's a lot less consensus on what we do next. Many institutions are hospitalizing all of these patients for a mandatory 24 observation plus or minus a repeat head CT. But is this really necessary? How much does it cost? And how often does the feared complication of the delayed hemorrhage actually happen? When you consider how common this problem is, it's surprising to think that up until about 2010, the world's literature on this consisted largely of case reports and a few small case series. The literature demonstrated that if you whack your head or fall while you're on warfarin, you do have an increased risk of intracranial hemorrhage than in a similar, non-anticoagulated population. And when you consider that the majority of anticoagulated patients tend to be older individuals with more chronic health problems, such as atrial fib, stroke, valvular heart disease, and the like, you're starting with a population that is already at higher risk of injury than a younger, more healthy cohort. But the difficulty with relying on case reports is that you don't have an appreciation for the denominator. How many patients did they see before a single patient with a delayed hemorrhage was identified? This paper, published by Kayan et al. In 2010, was really the first paper to try and quantify the risk for us. This is a prospective, observational cohort study that enrolled 137 consecutive patients that were all anticoagulated and sustained minor head injury. All of these patients had a negative initial head CT, and all had an initial GCS of 14 to 15. These patients were observed for 20 to 24 hours with a repeat head CT after observation. Only 2 of the 137 patients, or 1.4%, developed any delayed hemorrhage. Both were clinically asymptomatic and no interventions were required. In fact, both were discharged within 24 hours of the identification of their hemorrhages, and both of them were continued on anticoagulation. No deaths occurred in this population, and of note, both of the 2 that developed delayed hemorrhage were also on antiplatelet therapy as well as being anticoagulated. This next paper was published in the Annals of Emergency Medicine in 2012. This was an Italian study, and they enrolled 97 patients who were anticoagulated on warfarin and had sustained minor head injury. 10 patients declined to participate any further, so we're left with a total of 87 patients. What they found was that at 24 hours, 5 patients had developed a delayed hemorrhage not detected on their initial CT scan. Of these 5, only 1 had neurologic deterioration and required an intervention, which was drainage of a subdural. In fact, 2 of the 5 were discharged despite having a hemorrhage because they were symptom-free with what they described as minimal detectable hemorrhage. There were 2 more hemorrhages detected after discharge, on day 2 and on day 8, both of these patients having had an INR greater than 3. The authors concluded that based on this data, we should be admitting all anticoagulated patients who bonk their heads. But if the point of admitting for 24 hours and repeating a head CT is to catch all of the delayed hemorrhages, this strategy would have missed more than 25% of the hemorrhages that occurred. So it seems to me that maybe this isn't such a great strategy. I also think it's worth pointing out that while this paper is often cited as the source of where the 6% in the widely quoted 0.6 to 6% risk of delayed hemorrhage after an anticoagulated head bonk comes from, it was a study of only 87 patients, making it a bit of an outlier, as all of the other papers looking at this demonstrate a rate of delayed hemorrhage much closer to 1%. I don't doubt that this is what happened in their cohort, but I do think that basing a clinical strategy on a sample of only 87 patients is completely ludicrous, particularly in light of the fact that we now have ample data. So let's move on and review the rest of it. This paper was published in the same journal as the last study and included a much larger cohort. This paper is probably the best evidence we have to date, being by far the largest individual study, enrolling over 1,000 patients. It looked at both patients on warfarin as well as clopidogrel, but for this discussion, I'm only going to look at the folks on warfarin. In this paper, 768 of the subjects were taking warfarin and had minor head trauma. Of those, the majority underwent an initial head CT. Just under 6% of the patients did not have an initial CT for a variety of reasons, and those patients were all followed clinically for 2 weeks following their head bunk, and none of them had an adverse event. Of the 724 patients that did have an initial head CT, about 5% had an intracranial hemorrhage, while 95% had a negative CT. The 687 patients with a negative CT were followed for 14 days, and of those, only 4, or 0.6%, developed delayed intracranial hemorrhage. The biggest limitation with this paper is that due to ethical concerns, the authors did not get a follow-up CT on all of the patients, so it is possible that there may have been a few completely asymptomatic delayed hemorrhages that were not diagnosed. However, of the 4 patients that had a delayed hemorrhage, all had a change in clinical condition or mental status that led to repeat imaging. And the big news here is that only 1 of the 4 occurred within 24 hours of the initial head CT. In fact, 2 occurred on day 3, and the last not until day 7. So unless the patient needed to be admitted for other reasons, only 1 of these patients would have had their delayed hemorrhage during a 24-hour observation. In this study, the patients that died hemorrhaged on days 3 and 7, and the really scary part? Both had subtherapeutic INRs. This paper was published as a research abstract, so it doesn't go into quite as much detail as I would really like. It's a systematic review of 5 studies of adult patients with minor head injury that were on warfarin. I give these authors major props because they combed through 294 studies to pick out these 5. The review included 1,316 patients that met the criteria of being on warfarin with minor head injury defined as a GCS of 14 or greater. The most common mechanism of injury was due to a fall, and their primary outcome was the identification of any intracranial bleeding on a follow-up CT after an initial negative head CT in the emergency department. This outcome was noted in 17 of the patients, representing 1.29% of the study population. Of these, only 3 required neurosurgical intervention. The authors did not report on whether there were any deaths in this cohort, which is really the biggest limitation of this research abstract. They do report that the average INR of the population with a delayed hemorrhage was 2.6 plus or minus 1.2. This is the most recent paper on this topic and was published last year. They enrolled 298 patients who were on warfarin that sustained a minor head injury, excluding patients with polytrauma. This was an older cohort with a median age of 71, and as you might imagine, the most common mechanism of injury was again a ground-level fall in over 90% of the subjects. All but 3 were admitted for observation, with the 3 who weren't having signed out AMA. About half the patients had a therapeutic INR, while 32% were subtherapeutic and 14% were supratherapeutic. During observation, only 2 patients developed any symptoms of possible neurologic deterioration, and of these, 1 had developed a delayed hemorrhage diagnosed on day 2. 9 other patients had a follow-up CT scan, but the rest were all followed clinically, and nobody else had any neurologic deterioration. Again, due to ethical reasons, they did not rescan everybody. So in this paper, the incidence of delayed hemorrhage was even lower. Only 0.3% of warfarinized patients developed delayed hemorrhage. Granted, just like in the Nijishima paper, it is possible that there may have been a couple of patients that had an asymptomatic delayed hemorrhage that went undetected, but these were felt to be of little significance since they had no patients that developed adverse sequelae for up to 2 weeks following the injury. I agree with the authors. Intervening on an asymptomatic hemorrhage can only cause harm without benefit. Now for the frightening part of this. 3 of the 295, or 1% of the patients that were admitted for observation after their head injury, died from a nosocomial pneumonia acquired during their hospitalization. So they admitted a patient who fell and bumped their head and was asymptomatic so that they could be observed, and the patient ended up dying because they were hospitalized. None of these three were the one that had the hemorrhage. So to me, this paper demonstrated that we might actually harm more patients than we help by admitting these patients. Sadly, this is the only paper I've ever found that even bothered to ask the question, are we doing any harm with this practice? Based on these papers, the incidence of delayed hemorrhage following closed head injury is pretty low, even in an anticoagulated cohort. In fact, across all of these papers, it is overall less than 1%. And just FYI, I did not include the Garner-Gray systematic review in my averages because their data duplicates 3 of the above papers. When you look at what happened to the rare patient that did have a delayed hemorrhage, the majority did not require any neurosurgical intervention, and very few died. Of all those that did require intervention, they all had some kind of clinical deterioration that could have been detected on examination. Of those that had a hemorrhage that did not require intervention, none of them died during follow-up. And not every patient in these studies had a follow-up CT, but none of the asymptomatic patients had any adverse sequelae either. The question that we should be asking here becomes, is it clinically important that we detect these delayed hemorrhages if the patient is symptom-free? Based on all of the evidence we have, it appears that the answer to this question is no. This is an editorial that was published in the Annals of Emergency Medicine in the same issue as the Nijishima and Menedito papers in 2012. Based on the literature available at the time, he did the napkin math on admitting all anticoagulated patients with head injury and repeat CT scanning, and he figured out that based on the average cost in 2012 numbers, so it's probably higher now, of a non-contrast head CT and a 24-hour admission for observation, that it will cost a little over $1 million to detect one delayed hemorrhage. And considering that the majority of these don't need anything done, with only 0.2% of patients going on to need neurosurgical intervention, now we're talking about spending closer to $5 to $10 million per patient that actually requires an intervention. So the numbers are actually even worse than what he published. Now we have to ask ourselves, is it really reasonable to be doing this? Just to make things even more challenging, there were multiple patients in these studies that didn't have their delayed hemorrhages within that 24-hour window. In fact, some of them occurred as far out as 7 to 8 days after their initial injury. So now are we going to hospitalize everybody for a week? If doing 24-hour observation isn't identifying the population that you're trying to catch, then why are we doing it? These numbers also don't account for the patients that develop nosocomial infections or iatrogenic complications during hospitalization, despite the fact that the Lim paper demonstrates that this actually caused more harm than benefit than was reaped by identifying a single delayed hemorrhage. This is our dirty laundry, folks. Nobody ever talks about it, but this is a conversation that we as a specialty and a medical community need to have. Unfortunately, we're always so focused on the potential benefits of any given intervention that we have a tendency to neglect to consider any of the harms. And frankly, I just don't think that our current approach is cost-effective either. The best evidence topics are a really nice read, and if you've never checked them out, I encourage you to do so. This paper looked at much of the same data that we looked at 2 slides ago and came to more or less the same conclusion. What we're currently doing just isn't supported by the evidence. In fact, the authors suggest that the risk of delayed hemorrhage is low enough that even in patients that are therapeutic, note not the super therapeutic frail little old lady with an INR of 9, please, that if the patient has a good support system where they can be observed at home, does not have other injuries that require hospitalization, and has an INR of 3 or less, and has the ability to return in the event of a change in mental status, it's reasonable to consider discharging those patients. So after all of that, what's a poor pit doc to do? This stuff is complicated. Here's the big caveat. None of the papers we looked at included any of the newer, novel oral anticoagulants such as rivaroxaban or apixaban. So while it's logical and likely that those would probably have a very similar or slightly lower risk profile, I don't have very much real data to back that assumption up yet. But as far as treating patients on warfarin, delayed hemorrhage happens. I just don't think it happens nearly as frequently as we thought, and bad outcomes due to delayed hemorrhage are even rarer. The data we have seems to demonstrate a less than 1% overall risk of delayed hemorrhage when you hit your head while on warfarin. The hard question now is, what do we do with that information? All right, I need to insert an opinion alert here. This is my interpretation of what I think we should be doing based on this literature. My approach is pretty straightforward. Risk stratify and talk to the patient. If the patient is super therapeutic, I still admit them, not because I have any good data for this, more because I don't have enough data for this. But if the patient is symptom-free, with an INR that is therapeutic or subtherapeutic, and they don't have other injuries that would require hospitalization, then I think it would be very reasonable to talk to the patient and do some shared decision-making. The things that make me more likely to admit someone is if the patient lives alone or doesn't have anyone to check on them, or if they are really high risk of falling again for some reason. You could make the argument that those people shouldn't be anticoagulated in the first place if they're that high risk of falling, but that's a conversation for another day. If the patient has good support, and the patient or family, as appropriate, are comfortable accepting a 1% risk of delayed bleeding and an even smaller risk of death or disability, then I think it's absolutely reasonable to allow those patients to choose to decline admission and elect to go home. Well, that's a wrap, folks. I'm wishing you a warm, safe, and happy year ahead, and we'll talk again in a few months with some more emergency medicine goodness. Ta-ta for now.